We're here to talk to Congressman Spanberger. And I want to thank everyone for being here. My name is Laurelyn Clark. We're excited to join Congressman Spanberger on prescription drug costs. It's my pleasure to introduce our congressman. It's my pleasure, Congressman Abigail Spanberger.
Thank you so much. Thank you for the introduction, Laurelyn, and thank you so much for being here today. This is fun, isn't it?
Yeah.
So I'm grateful for you all for your willingness to come together and talk about prescription drug pricing and larger healthcare issues. Just to give a quick blip on what it is that we've been focused on in Congress. Just this past week, we passed H.R. 3, which is the Elijah Cummings Lower Drug Costs Now Act. And that bill is monumental in terms of what it would do and the capacity that it has to lower the cost of prescription drugs for all Americans. Specifically, that bill would give Medicare the power to negotiate its prescription drugs and the prices that it pays under Part D, but those savings would extend to all Americans with commercial plans. So this is such an important piece of legislation. It did pass with bipartisan support, and I'm so proud of the work that went into putting this piece of legislation forward. In addition to that, I had two bills myself, one focused on transparency in drug pricing, and that one passed on the House floor 403-0, because indeed, when we are talking about prescription drugs and the cost and transparency issue, being able to understand what is contributing to the rising cost of prescription drugs is something that all members of Congress can agree on. So that's good to find that commonality. And then I've also introduced another bill that would stop some of the patent gamesmanship that keep biosimilars, so the generic versions of biologic medications, from coming to market in a timely fashion and at an affordable cost. So I'll turn it back to you, Laurelyn, and I look forward to the discussion.
It's been a pleasure hearing from you, and we have a lot of people here that has questions and want to talk with you. But before that, I'd like to let everyone know that you have addressed the prescription drug crisis and making things transparent so that everyone understands what you're trying to do. Giving Medicaid the power to negotiate is great here in Virginia. Thank you. So are we ready for this conversation, you guys? So who wants to go first? How you good?
I'm Shelby from Chesterfield, and I have lived with type 2 diabetes for 20 years. I'm self-employed and rely on the ACA for health care. I'm not old enough for Medicare. My prescription cost for one of my drugs has gone from $80 in 2017, $80 for 90 days. This past year, $2,100 for 90 days.
Wow.
So I'm concerned about the pricing, clearly, and I'm also concerned about protecting pre-existing conditions or protecting people with pre-existing conditions in terms of the ACA going forward. So I'm wondering, how is this bill going to help me?
So in addition to H.R. 3, which I've discussed so far, we also have another bill in Congress that is affirming our commitment to pre-existing conditions protections for those with pre-existing conditions. As an element of the ACA, we have affirmed when that bill first went into place that, in fact, those with pre-existing conditions would be protected if they were later in a place of changing their insurance coverage. But we have a standalone bill affirming those protections, and they're vital to those with chronic illnesses, those who face illness at some point in their life. As it relates to insulin and the challenges faced by so many individuals with diabetes across our community, yours is is the most frequent point of conversation that I have heard across the district, because the idea that your prescription that you buy went from $80 to $2,100 in a 3-month time period, 3-year, for a 90-day supply, that's unbelievable and substantial. And so recognizing what what the value of allowing Medicare Part D to negotiate is it's that first step. So Medicare Part D would negotiate those prescription drug prices initially, and then those cost savings would extend to all Americans on a commercial plan. And so the value there is significant because I believe in the power of the competitive market, and certainly competition is going to take us away from a $2,100 a month charge for a 90-day supply.
Yeah, and that's not even for insulin. We have another woman who was going to be here with us today, but she's actually in Canada this weekend buying her insulin.
She's in Canada buying her drugs right now.
She can go there without a prescription, walk into a drugstore, get a vial of insulin for $30. Here, with insurance and with a prescription, it's $240 for the same vial of insulin.
Wow.
So
That's sad.
And this is so frequent. I recently did a prescription drug roundtable, and we had a family attend that, and one of the parents and one of the children are both diabetic, and they were talking about how they stack their purchase of insulin throughout the year in order to be able to pay for both the parent's insulin supply and the child's insulin supply. And when you look at the cost of these life-saving, very, very basic, straightforward medication like insulin, and the cost comparisons to other countries, it's shameful what we pay. Yeah.
Anyone else?
Yes,
Let's join the conversation.
I will. Hi, I'm Donna Denson. I'm also known as the dynamic diabetic. So I'm from Chesterfield, and I'm a retired person. So the cost going up really affects me in that means something else has to go because I'm on a fixed income. I've also been affected by the fact that drugs going up. My insurance company removed drugs that I couldn't take anymore because they were so expensive. And then that caused me almost 3 years to get myself back in control on another medication. And then the interesting thing to me was when I was looking at anything with insulin, no matter how it was delivered, they were all the same price. And I couldn't understand that. How are they all the same price? That sounds like manipulation to me. So how is this bill going to change that? And I have private insurance. So how is that going to dribble down to me? Is the insurance company going to save, or am I going to save? That's what I want to know.
So the challenge with prescription drug prices and the fact that they have been rising significantly over even just a short period of time is that you get a lot of it's their fault. And so is it coming from the pharmaceutical companies? Is it coming from the pharmacy benefit managers?
Yeah.
Where is this cost increase? And whether you have a private insurer, Medicare, Part D, or but where is the increase happening? And so without transparency, it becomes very difficult for the consumer, for a medical provider to understand why these costs are. I just had the experience of picking up a prescription yesterday, and they called in the prescription for one topical cream. It was about $100. But then with this cost-saving coupon that you could find online, it was $32. And if you don't have the time, and in fact I didn't, because 3 months ago is when they wrote the prescription, to actually dig into it and determine what the costs are, what potential savings exist, then you're paying these high prices or sometimes abandoning your medication. So where transparency, and I'll go back to the bill that we passed already in the House, it requires that the rebates that pharmacy benefit managers, so the middleman organization between the point of production with a pharmaceutical company and the patient picking up at a pharmacy, what rebates might be within that pipeline. Because many would say that, in fact, they're a contributing factor to the costs and increase in costs. Mm-hmm. But without transparency, you don't totally know. So, my bill, it's not going to immediately change things, but it provides that transparency. You at least know how much they do or don't affect the cost of prescription drugs. Allow researchers to dig into it, allow medical professionals, doctors, nurses, pharmacists to understand. And so that level of transparency will be incredibly important when you're talking about the fact that how is it that across the board it's all the same price, but it's all the same price that's at a pretty unaffordable level. And then when it comes to the HR3, for anyone who is on Medicare Part D, the benefit is clear in that Medicare Part D can now negotiate its prescription drug prices. And this is vital because when we're talking about competition that exists, the VA can negotiate. And sir, I see you're a veteran. The VA can negotiate its prescription drugs, which is all that we're asking is to give that same power to Medicare and then to extend the benefits of that competition to private insurers. So, the first step is this bill passed the House of Representatives. The next step is it goes to the Senate. Ideally, it'll get a vote. Ideally, it'll pass. And then from there, it would go to the president for signing. But one of the things that the president has frequently said in the past is that he supports allowing Medicare the ability to negotiate its prescription drug prices. It's vitally important. It's an element of competition that shouldn't be stopped. So,
Excellent. Thank you.
Let's keep the conversation going.
Hello, Senator Spanberger. Nice to see you.
Nice to see you, sir.
Yes. One of my questions is that I'm a member of the healthcare workers, part of Richmond, Virginia.
Yep.
Yes. And thank you for help passing that bill, H.R. 3, on prescription drugs. And I would like to know one of the things that will really help prescription drugs for the people, because we are the healthcare workers, my sister and I, of our mother, and we are the spokesman for her. So let's name me one of the things that the prescription drugs where it would help her.
And does she currently is on Medicare?
Yes, she is.
Yes.
She's 93.
Oh my goodness.
What a blessing.
Wow, what a blessing, right?
That is a blessing.
So allowing for the competition and for Medicare to negotiate its prescription drugs would be valuable if she is on medication on a regular basis. The overall cost would be bringing down those costs would be incredibly important. In addition to that, this bill would also put in caps for out-of-pocket costs for Medicare Part D users. So that's important too, because so much of what I hear as it relates to the cost of prescription drugs is if you are chronically ill or there are medications that you need over and over and over, it gets to the point where if you can afford it 1 month, but now you're looking at a full year. So knowing that there would be a cap to those out-of-pocket amounts is incredibly important, particularly for individuals on fixed income. And I also thank you, and I know there's some home health care workers here, so thank you all for the work that you do. When we talk about the larger discussion related to health care, it's the people who are, helping patients and our seniors who need additional assistance, or anyone who needs additional assistance at home, that is allowing so many Americans to be able to age in place. So thank you for the work that you do, because I know it's a lot, but it's so incredibly important to those who you're helping.
Thank you.
Thank you.
Thank you, sir.
Anyone else want to join this conversation? Come on in.
My name's Rick Kinnaird. I'm Shelby's husband. I do not have diabetes, but I'm living with someone who does. And one of the things Shelby didn't mention, by the way, she researches everything. So when it came to her insurance, she made sure that the insurance plan she got covered her medicine. 3 or 6 months in, they said, oh, we're not going to cover that anymore. You can only sign up once, but they can kick you off the medicine anytime they want.
Wow. So you're already on the insurance.
So I picked a plan based on the fact that it covered all my prescriptions. When I went to order my prescription, the first time I ordered it, everything was fine. I went in June to get my next 90-day supply, and the insurance company decided I didn't need to be taking that anymore, that I should switch to something else when my doctor wanted me to be on the other one. I assume it was financially beneficial for them to move me to the other drug. So I think this is called non-medical switching. But anyway.
What happened to me? They said, you can't take that anymore. We're not going to cover that anymore, so you have to choose something else.
And that was in the middle of the plan year when here I thought I'm getting one plan and it's changed.
Wow. And then because it's not open enrollment time frame, or you didn't have a life-changing event,
Exactly.
you couldn't actually go ahead and then change your insurance.
Exactly. Yeah.
Wow. Okay.
You want more fun and games?
Let me have it.
So I was down in Mexico. So I go into a pharmacy. My wife's taking Trulicity. I say, hey, you got Trulicity? They go, yeah. I said, how much is it? They go, $400. So I take a picture, I send it back to Shelby. I said, how much would this cost you in the States? $2,095. I can't buy it because you can only bring in a 3-month supply of your medicine. I can't bring it in for her. I sent a buddy of mine, Raimundo. I said, hey, Raimundo, can you mail this to me? He goes, Rick, man, no, I can't because as soon as it hits customs, they'll send it back because you can buy it in the States.
Yeah.
Yeah, nice. Now, how can Mexico get drugs that come from the U.S. and charge 1/5 of what we do?
Yeah.
Just ask your big pharma guys that, you know.
Yeah, and these are the sorts of conversations. I have colleagues who are from states along the northern border, and they say they have constituents just on a weekly basis, practically, who are telling them that they go across the border to Canada to get their prescription drugs, and they're exactly the same medication that they're buying, and stateside they're X dollar, and across the border in Canada they're so much cheaper. And so this is really, when we're looking at what we've been focused on in Congress, in the House of Representatives, it's bringing a basic level of fairness to prescription drug pricing. So many of these incredible drugs that are life-saving drugs were developed by U.S. researchers here in the United States, and yet the profits keep coming on the backs of the American people who need these drugs. But due to competition and better pricing in Canada or Mexico, they're significantly cheaper.
There was an episode of Vice where they went to China, where they have every October the generic drug makers get together and try to get people to buy stuff. And there was a woman who was paying $20,000 a month for her cancer drug, and they found it there. And the guy said, yeah, we can make you 2 kilos for $6,000. They said, here, take this sample back. The sample they gave them had a street value of $10 million. Wow. And it was the same stuff.
That's sad. Let's keep this conversation going. Who else has something that they would like to share with Congressman Spanberger?
Hi, my name is CJ, and I am from Glen Allen, Virginia. And I'm kind of new to this because I was just diagnosed in March with type 2 diabetes. I'm a work-at-home mom. I have 3 kids. And, we're fortunate right now with my husband working full time. So, that's how we have insurance and everything like that. But my concern is that, we make too much. So, we're not able to afford Medicare, because we just make too much. We come from both sides of our family do have diabetes. I have a family member right now who is fighting with the insurance companies just to get the insulin that she needs. For those of us who are not able to have Medicare, what can we do?
And this is the constant refrain. These are the discussions that I'm hearing out and about across the district, is that people will say, well, I'm fine right now. I can afford the medication that I need, but what about people like me? I have had constituents tell me about Facebook groups where diabetics and those with children who have diabetes are trading supplies based on who can get what they need and who needs what they need and where their insurance and whether or not they've gotten too much so far. And that's not how the system is supposed to work. That's not good for anyone. It's not good for the individual who has a chronic illness. It's not good for the kids who have a parent with a chronic illness. It's not good for the economy if you have to miss work because you can't take your medication. It's not good for the community overall. And so, the focus that we have in Congress right now, laser focus on working to lower the cost of prescription drugs. It's this level of anxiety, I think you could call it, that people are experiencing that we're trying to address, because there are people who are faced with the decision of whether or not they pick up their prescription drug at the pharmacy or whether or not they buy a full load of groceries. And that doesn't mean that person doesn't need those prescriptions. That just means they're going without. And then what does that mean if they show up in the ER a couple weeks later or more tragic stories, particularly as it relates to diabetes, more tragic endings if they don't get the dosage and the insulin that they're required. And so where we're working, I'll harken back to HR 3 because I'm so proud of the work that we've done on this bill, is that competition, bringing both through the competition that Medicare Part D can initiate, an understanding that there can't be price fixing. There can't be these outrageous prices for life-saving medication that was invented 100 years ago. That's simplistic in its formulation and basic in its life-saving ability, but sometimes out of the reach for individuals or families. And so the focus on that competition and on the transparency is so vital to ensuring that people who might be in a place to be able to afford their prescription drugs don't have to worry what happens if a spouse changes jobs, or what happens if they want to start their own business, or what happens if they want to go out, or what happens when they're entering retirement. This level of anxiety that exists for those with chronic illness, it impacts all of us, whether we have an illness
Definitely.
or not.
And, just in addition, we have a son who has special needs, so it's like not only that I'm concerned about my needs, but my son's needs as well. And the bills are piling up, so, yeah.
Thank you for being here.
Wonderful. Anyone else?
Yes, I'm Brenda Glenn, and I'm from Henrico, and I'm a home health person that take care of my mom's. I left my job in 2013 because she was diagnosed with dementia. So my struggle is when they changed different insurances that you have to wait so long to get back in the system, and in the meantime, I'm struggling trying to get her medications because she have to have it. And by me leaving my job in 2013 to take care of her, so I'm not really making a whole lot of money. So now it's like both of us is really scrambling for our prescriptions. So, with this bill that you passed, I hope eventually it would try to help, some kind of way it could, help us.
Well, and thank you for sharing that, and thank you for your work in helping your mother. She's very, very lucky to have you. But when we're looking at the large-scale healthcare crisis, the fact that a daughter is leaving her job and the larger implications that has on your life, in order for your mother to be able to get the support that she needs, that creates a challenge all in and of itself. And while we are working for to lower health care costs and prescription drug pricing in particular, that's not going to solve that issue all at once. And so when we're looking into the future with an aging population and community members who will need home health care support and workers, how do we know that we have a pipeline of those who are going to be able to go in, whether they're children who are supporting parents or employed home health care workers? That's their priority, that's their professional role. The challenge really exists. Where are we going to be in 10, 15 years with the supply of home health care workers, given how many aging Americans we have who do want to age in place and at home? So that is also a part of the larger discussion that we've been talking about in the halls of Congress and in some of the committee hearings is, what do we expect in coming years in terms of what the needs of the population will be?
Thank you.
Well, as a home care worker myself, I cared for a lady who recently had a stroke. Things got kind of bad, and somehow or another her insurance got changed. And because of that, she went about a month without medication. Because of that, not only did she not get her medication, I didn't get paid. So things get mucky when, people are sick.
Yeah.
And I thank you for pushing this bill to helping to keep people like me and my client medicated. Yeah. Because without our medication, there's going to be a lot less people around to do the work that we do.
And with your patient, I mean, were you in the role of having to advocate for her to ensure that she got her medication?
Yes, I called and I made phone calls because they changed her from one pay agency to another pay agency, and one insurance to another insurance, and this insurance didn't cover that, and that insurance, it just got mind-boggling for me. And then it was like, okay, I'm not the right person to do this.
Yeah.
So I started calling different ones, and then I wound up having to call her family because at the time she lived with me. So I was trying to figure out how to keep her healthy.
Yeah.
I mean, she was 74 years old, and she had the first stroke she had, she lost the whole left side of her brain. So the second stroke, she started losing part of her right side of her brain. And because everyone was changing things up, I was lost. So I called her family and I thought, I can't handle this.
Yeah.
You know, this is not my expertise. So I had to get them involved and send her back to them because I couldn't take care of her, because without her medication, I didn't want to take the chance of her having another stroke on my watch.
Yeah.
It's
Similar problem. A friend of mine who's younger than me, I got a call saying, Corey's in trouble. So I flew out to Las Vegas, I saw him, and I realize now in retrospect, he just wasn't mentally able to take care of himself, and he had diabetes, and he had been taking his medicine, and then he just stopped taking his medicine, and then, yeah, he couldn't afford it, and it's yeah, he didn't have health care. He had his own business. He's on dialysis, which Richard Nixon did put through, so thank you, Dick. You know, he just wasn't able to do things for himself, and he ended up dying. And
That's so
when
sad.
I called, they called me because they wanted to know if he had a what do they call it, a living will, and I knew where it was because we got that done. And I asked the doctor on duty, I said, well, what happened? He said all systems were shot. You know, he just wasn't able to do it. And you know, come on, we're the richest country in the world. You know, I mean, I go around and I study ancient civilizations. The Incas took care of all their people. Everybody got fed, everybody got taken care of. We can't do that here? Come on.
There's a problem. Let's keep this conversation going.
Yes, I'm a home care worker as well, and I've been doing this over 20 years, and I have run into quite a few people who they have insurance and they have multiple insurance, but I have some of the clients that I'm working with, they have too many insurances, and all of them can't decide on who's going to pay for the medication because they're not the primary insurance. So the person ends up going without the insurance, without the medication for a period of time. So how do you figure out which insurance can actually pay without it being a year before the person gets to pay for medication, or they have to go so many months or weeks without without being medicated, and then they get weaker and they get sicker when they really could have been taken care of in a timely fashion. And if you can get the medication in 6 months, is it possible to get that additional 6 month supply while the insurance is paying before you decide which one is not going to pay?
And so the problem that you just described is clearly from kind of the administrative side. It is just waiting. But what is the impact you've seen on your patients?
Well, they're declining because they're not getting their medication when they should, and then they're using the emergency room as their doctor instead of actually going to the doctor they were going to, or you can't go to the pharmacy they used to go to because that insurance says, okay, you have 3 insurances, this is not your primary, I'm not the primary, you got Medicaid, Medicare, or the another additional insurance. They're not paying. So how does that person get their medication when they actually physically have insurance, but it's not paying for the medication they need?
And then the costs on the larger community, if they are using the emergency room as their provider, and maybe their insurance companies are fighting over who pays for that.
Yeah, that too. That is a problem too. That even at the emergency room, they're still trying to decide who is going to pay, and it ends up nobody's paying that bill that's coming back to that person and putting more stress on them on top of not having the medicine.
And what could have otherwise just been preventative care becomes reactionary, more expensive,
Yes.
and it's more expensive for them. It drives up premiums, and it impacts everyone across
Everybody.
the board. Wow.
Sad. let's keep this conversation going. Anyone?
Yeah. I'm a caregiver as well. My father's 99.
That's a blessing.
And he's going strong. He tells me it's 116. And I'm like, I can't handle it, Dad. He's a character. But he's fortunately a veteran. And I can see from what you're talking about, the VA is so good for him. And his situation is so different from what I'm hearing from my cohorts here that if I'm correct in understanding this bill, that's going to help even that out, right?
So from the prescription drug pricing side of things, yes. But it is slightly different because if you're in the VA system, the healthcare system is pretty substantially different. But when we look at the VA as a government program and Medicare as a government program, the fact that the VA can negotiate its prescription drugs, the fact that they can have them at a much more affordable rate than Medicare. Medicare just doesn't even have the power currently to negotiate, and there the impact is on the individual patient. The larger system, of course, because there is so much power. When you look at how many Americans nationwide are on Medicare and Medicare Part D, there is a real power in saying we as a group are going to negotiate. But moving forward optimistically, when our bill gets signed into law, Medicare will have the power to be able to do that. And so kind of the ease of experience of being able to just get the prescriptions that your dad needs under the VA system will ideally be something that we can duplicate within the Medicare system.
That's so important. And for me, Dad's 99. My mom passed with diabetes last year at 94. So I've got really good genes, but I want to make sure that I can afford to live as long as they have. So whole thing is just so terrifying to
Really
look at the
is.
cost rising like it is. So thank you very much.
Thank you.
Yes, thank you again also. One of the questions that I have.
Any more questions?
With H.R. 3, that bill went through, and you said it was bipartisan. And you say you had 2 more bills that's coming up, and is that bipartisan?
Thank you for that question. So H.R. 3 did go through. We did have bipartisan support. So I'm a Democrat. Not a tremendous amount of support on the Republican side, but we did have a couple join us, so that makes it bipartisan. But the other bills that I mentioned, my transparency bill for pharmacy benefit managers and pricings and the rebates that go along with that bill was totally bipartisan. I introduced it with a Republican co-lead, and it passed out of the House with 403 to 0. Not everybody was present that day on that voting day, so we didn't get everybody, but nobody voted against it. And then my other bill, which is focused on biosimilars, so the generic medicine versions of biologic medication, so the infusion-style medicines, that bill I introduced with a colleague named Tom Reed, who's a Republican from upstate New York. So it's bipartisan at the point of introduction. We're continuing to get more people, both Republicans and Democrats, on that bill. And we have a companion bill in the Senate, which is also bipartisan as well. So that one ideally will continue to move forward, and hopefully we'll get a strong showing of support into the future once that bill actually gets a vote. It hasn't come up for a vote yet. It's still going through the committee process.
Oh, great.
Thank you. And I think it's important, and thank you for raising this, when we're looking at the fact that issues of healthcare pricing, issues of the cost of prescription drugs, this isn't an issue that is particular to one party or another. This is an issue that really impacts every American, regardless of where their political ideology is or isn't. And so I think it's incredibly important that we have worked, particularly with and I'll mention the bills that I introduced, we worked to make sure that we could get a broader coalition because to create the longer term stability in our legislation, I think it is important to bring a broader coalition together. And with H.R. 3, it did have tremendous support on the Democratic side of the aisle and a little bit less on the Republican side of the aisle, but I'm so grateful to my colleagues across the political spectrum, again, for recognizing here it's the power of competition. Here it's recognizing the kind of crushing burden that prescription drug pricing has on so many individuals, our seniors, families across the country, and that if we want to advocate not just for their needs, but for the strength of the community and the economy, that ensuring that they aren't choosing between putting food on the table and buying prescription drugs, is ensuring that that's not a decision anyone's making is important to all of us,
Exactly.
whether we need those prescription drugs or not
Yes.
now, because of course we all do at some point or another.
Exactly.
So.
Yeah.
As a home care worker and an advocate for home care, I have a question. How can we, as the general public, help your cause? Is there someone we should call? Is there emails that we can send? Or is there something that we can do to help make this more of a reality?
Well, one of the things that I think we've been facing as members of Congress is we've been doing a lot of good work, and not everybody knows about it.
Exactly.
So, I think this bill, H.R. 3, that has passed out of the House of Representatives, we wanted to get a vote in the Senate, which means we need the Senate to be willing to take it up. So, a couple things that you can do is just talk about the efforts that we've undertaken. Talk about this bill in particular. This one, it's such a expansive and foundational bill as it relates to prescription drug pricing. So there's been a lot of write-ups in the paper and news stories about it. So there's a kind of body of information. So share it on Facebook. Talk to your friends about it. Certainly for the home healthcare workers, talk to your colleagues about it. And then where you have the time and the ability to do so, advocate with our senators here in Virginia, with your friends and colleagues and counterparts in different states. Make sure they're advocating with their senators to push for this bill to get a vote in the Senate. And then I think ensuring that advocacy groups are engaged and vocal, and they can be a really great path for talking about these issues. AARP is very, very vocal. SEIU is very, very vocal.
Yes, we are.
and different organizations that do advocacy on behalf of those with chronic illnesses or different communities. It's incredibly important.
Well, I thank you for the work that you do and that you have done. And trust me, we will be very vocal on that cause, because as home care workers, our clients depend on it. Because a lot of them, they don't come from money. And they've worked all their lives and they deserve to age gracefully. Without having to, maybe I'll just take half a pill today, I'll skip it tomorrow, and then get something to eat the next day. Because believe it or not, a lot of them go miss a meal here and there. And a lot of them don't need to do that.
Yeah.
So I'm extremely grateful for the work that you're doing and helping all of us here today.
Thank you. Well, and I'm grateful for you all sharing your stories, asking questions, and being engaged on this issue. And I think the important thing to remember is for every person who's here, there are 10 or 20 more people like you. And so wherever you can be a voice and share a story and make it known to us, I think that's so vitally, vitally important. And Laura Lynn, thank you for bringing this great group together. And certainly thank you to SEIU for always being so engaged, not just in community, not just, in your role as a home healthcare worker, but advocating, interestingly, advocating for your patients so substantially. Thank you. Thank you. Thank you.
So I appreciate all the work with regard to prescription drugs. In the diabetes world, there's also a lot of technology. So, for example, I don't have to finger stick to take my blood sugar anymore. I have something I wear in my arm, and I can wave my phone over my arm and take my blood sugar. However, that device is not covered by insurance. For me, if you take insulin, no problem. If you, basically, I'm type 2, I don't take insulin, so it's not covered covered for me. And my insurance company goes one step further. It's not only that I don't take insulin, it's that I don't take 2 different types of insulin. So here's this device that's the best thing I've ever done for my diabetes management that's not available to me and a whole lot of other people. So is there any thought of including devices in this list of prescription drugs?
So are you forced to pay out of pocket for the device?
Yeah, I have a manufacturer's coupon, but it's, I think, $75 a month.
And so what would be the alternative if you didn't have this device?
Finger sticks.
Finger sticks.
So I'm not going to test my blood sugar nearly as often. So now I scan and I can see what my blood sugar's done over the last 8 hours. And I can take that, my doctor can download it and he can see what I've done for the past 90 days. I mean, it's fabulous technology.
Which keeps you from spiking, which keeps you from having
exactly.
health issues, which keeps you out of the emergency room and everything else.
Exactly. I mean, it's the best preventative thing I've ever done.
Yeah.
And it's not available. I mean, if I couldn't, I mean, a lot of people can't afford it, you know? And so I would just like to see the prescription drug list expanded to include devices as well.
Thank you.
That would be great. 'Cause I know a lot of our clients don't.
So she can see a spike and say, "Oh, that meal was not good for me." You know? Oh, yeah.
Shouldn't have eaten that.
Wow. Wow.
Yeah,
Anyone
it is
else?
life-changing.
Wow.
One of the things that I'm so proud of my healthcare workers is because not only taking care of those people that we take care of, but we have to educate their families also. And with you being here, really help us. Like she stated, she had to turn them over to her family, her healthcare person that she had, but she had to educate that family also and tell them about you and the healthcare program. So yes, your word will get out, and it will get out between all of us here.
Exactly, because not only we healthcare workers, we're educators. We all have to be, because once you get some knowledge, if you hold on to it, you're not helping anyone. You're hindering other people from learning. And as a healthcare provider, I educate my client, I educate their families. That's what we have to do as a human race. Don't get the information and hold on to it. Share it. It's not going to do you any good just holding on to it. Sharing it, because someone that might hear you, it might actually save someone's life. So, we all have to become educators.
And advocates like you are.
Oh, yeah, well, that I'm going to do to the day I'm gone. I'm going to advocate for everybody because that's in my soul.
Yeah.
I forget the numbers, but the number of people who are pre-diabetic in this country is huge. And if they get and nobody dies from diabetes, they die from complications due to diabetes. So people think, oh, it's not that big a deal. But the other thing, talking to what you were saying, Shelby, you were in that group where you had to talk to a spouse who didn't have diabetes, and they were pissed off because they couldn't keep cookies in the house anymore. Tell them that story. It's a great story.
It was a diabetes self-management training class, and so it was people with diabetes, and it was people that lived with them, loved them, whatever. And so it was a woman, and we had to pair up and talk about the emotional impact. And she's like, I can't go to Sweet Frog, I can't keep cookies in the can, have my Snicker bars anymore. And so we were in the little groups, then we got back in the big group, and I said, well, I'm going to have to say what we talked about. Are you okay? Your husband's in the room. Are you? Oh, yeah, he needs to hear it, and it'd be better coming from you.
And tell him what his reaction.
And he was like, honey, you can have Snicker bars. You can go to Sweet Frog.
Okay.
So I think there's a component of, as you were saying, training and telling the family, but also there's a lot of anger with some people that, oh, she's got diabetes and now I can't do this. And it's like, well, have you two talked about that? Oh, no, I haven't talked about it. Well, wait a minute.
Well, and linking it to the discussion related to the actual pricing of prescription drugs, there's a lot of anger around that. Because when you think about point in time when you're headed to the pharmacy to pick up, I have 3 daughters. One had an ear infection somewhat recently, and we took her to, it was after hours, we took her to a place, they called in a prescription, we go to pick it up, and it was close to $100 for an antibiotic. So I called them back and go through this whole rigmarole because, you know, one drug is X $14 with my copay, one is over $100, but they didn't mark the box, and just the whole process. And because there's so much confusion related to the cost of prescription drugs, because you can be on one medication and over just a couple years, it you know, by multiples goes up in price, there's a level of anxiety that exists where, you know, my initial reaction wasn't, oh, this drug must be more expensive. It was, something's wrong. Because when it comes to prescription drug pricing, there seems like there's always something wrong, and there's always some level of misunderstanding or lack of knowledge or confusion about how on earth can we continue in a place where these prescription drugs are so expensive. And so where we can actually have, you know, restore a bit of trust where people know, okay, well, you know, Medicare can negotiate. Okay, well, you know, this drug is expensive, but it's a negotiated rate, and discussion went into whether or not, you know, what's the fair price for this drug that's life-saving, that does require a lot to create it in the first place. But how's that priced in a way that's competitive and fair? And I think even to some degree restoring a little bit of faith that people have is important.
And help making it affordable.
Yeah.
Well, thank you everybody for coming and being a part of this conversation. We've enjoyed hearing from our Congresswoman, and things are going so well. We have time for one last question. Anyone?
All right.
I'll bring up one topic that you had a person that helped you get some health care, and we got talking about the regulations. And, you know, some people were talking, well, you ought to allow plans to go across state lines. And I said, I don't know if that's a good idea. And he said, what this fella said was, one of the problems is every state has slightly different regulations, so they have to keep track of all this. So if there was a bill at the federal level that said, okay, the gold plan is this, the silver plan is this, and every state had the same one, it would do a lot to decrease paperwork and those problems.
Thank you. Well, and you know, one of the primary goals of our current healthcare system with ACA is to ensure that at least you have the standards of care and the essential benefits, regardless of what healthcare plan you have, where you live, and whether you have a pre-existing condition. And you know, I think we've talked about so many great aspects or challenging aspects related to healthcare, that our healthcare system, the challenges people face, whether they have a chronic illness or related to aging. But the overall challenge that when people go to the pharmacy, they shouldn't be kind of racked with a pang of anxiety about what their prescription drug is going to be. They shouldn't have to go to another country. They frankly shouldn't have to go across state lines to be able to get the life-saving medication that they need. And I think this conversation, focused on people, focused on real stories, is exactly what should be driving this conversation. The notion that people and the American people are far more important than any lobby organization, than any special interest, than any sort of profit. Because at the end of the day, it's about strengthening our communities and strengthening our economy. And for the individual, it's about staying healthy and ensuring that they have the ability to pursue the American dream, just as the person right next to them who may not have a chronic illness does.
Exactly.
So thank you for all that you do, and thank you to everybody for being here.
Thank you. Thanks for everyone coming and sharing their stories. It's been a great time.
Thank you. Appreciate you.